Here we will look at the class beta-Proteobacteria, the order Neisseriaceae, and the family Neisseriaceae, where we will focus on the bacteria Neisseria meningitidis that causes meningitis. Also Neisseria gonorrhoeae that causes the sexually transmitted disease gonorrhea. Under beta-Proteobacteria, we will also focus on the order Burkholderiaceae, especially the family Burkholderiaceae, Burkholderia pseudomallei, and Burkholderia burkholderia that causes the disease melioidosis and glandus. Also, the family Alcaligenaceae, especially the bacteria Bordetella pertusis that causes the disease whooping cough. So here we are looking at the gram-negative aerobic cocci or Coccobacilli, especially in the family Neisseriaceae and Moraxellaceae. Okay. The important microbes are the Neisseria gonorrhoeae, meningitidis, Kingella corrodens, Kingella, kingae, and for Moraxellaceae, Moraxella catarrhalis, Acinetobacter, baumannii. So as mentioned earlier, Neisseria gonorrhoeae causes gonorrhea, Neisseria meningitidis, meningitis. The rest are mostly nosocomial infections. So this HESEC group is a name that given to Haemophilus, aggregatibacter, Cardiobacterium, Kingella, and Kingella that is now known to cause bacterial endocarditis, so a bacterial infection of the heart. Okay. So Neisseria are gram-negative aerobic cocci, often arranged in pairs. They are oxidase positive, non-motile, non-spore-forming, non-acid-fast. They have capsules and pili. So the capsules and the pili are their virulence determinants. They are mucosal parasites that die rapidly outside the human organism, and they are culturable. So under the family Neisseriaceae, there are two genera that are of interest, Neisseria and Kingella. So Neisseria gonorrhoeae is also known as gonococci, whereas Neisseria meningitidis, meningococcus, causes both meningitis and bacteremia. Neisseria gonorrhoeae is not normal flora and is an obligate pathogen, first described by A. Neisser in 1879, and is responsible for the sexually transmitted disease, gonorrhea. So it is able to adhere to the urogenital tract by the attachment pili, and then it is able to penetrate by endocytosis. Once inside the epithelial cell, it is able to multiply and grow. That's why the rapid growth will destroy the cells and release more gonococci to other surrounding cells and deeper structures. Sometimes the infection worsens to bacteremia or blood infection. So diagnosis of Neisseria gonorrhoeae is usually by microscopy, where the swab of purulent secretions is stained, and you can see the diplococci, kidney-shaped gram-negative reaction. Neisseria gonorrhoeae grows on special medium Diamartin agar and requires a capnate environment that is able to be produced by the candle jar method. So for differentiation, sugar utilization tests can be used. The primary site of infection is the urethra. The symptoms surface 2 to 7 days after infection. There is purulent urethral discharge and dysuria. So dysuria is pain when urinating. Whereas for women, the primary site of infection is the endocervix, with increased vaginal discharge, dysuria also. Asthmatic mothers that give birth to infants can cause blindness in infants because the bacteria will infect the eye of the infant. So this is known as the gonococcal ophthalmia neonatorum, purulent conjunctivitis. That is why nowadays the prevention is through eye drops immediately after birth. Asymptomatic males and females, especially females, are the major reservoir for this bacteria. So Neisseria gonorrhea infections are characterized as having high prevalence but low mortality. Although penicillin was the treatment of choice, penicillinase producing Neisseria gonorrhea has appeared. So nowadays, alternatives for penicillinase producing Neisseria gonorrhea are the third generation cephalosporins and the fluocinolones. Meningitis, they cause meningitis and sepsis. The diagnosis is also by direct detection of pathogens in the cerebrospinal fluid and blood. Okay, you will see bean-shaped cocci, and this usually occurs sporadically in the form of minor epidemics, mainly because meningitis have 12 serogroups. Most of the epidemics are caused by serogroup A, but vaccines are available. So when virulent meningococci colonize the nasopharyngeal mucosa, the invasion is via endocytosis, and the preferred site for the bacteria is the cerebral-central nervous system. But although it can also infect lungs, endocardium, and joints. So symptoms, usually severe headache, neck stiffness, vomiting, hypothermia, apnea, seizures, and coma. So Neisseria meningitis infections have low prevalence but high mortality. So this is in contrast to Neisseria gonorrhea that has high prevalence but low mortality. So basically, this shows the two strategies for an infectious agent. If the agent opts for low mortality, then chances are they will have high prevalence. But if the agent is characterized by high mortality, then the prevalence will be low, because when the infectious agent causes high mortality, the chances of spreading is limited. Okay, so this is similar to what we are experiencing now with COVID-19, where the mortality is low, and that's why you have very high prevalence. So normal flora and carrier rates are about 5 to 15%, as opposed to Neisseria gonorrhea, where it is not normal flora. And Neisseria meningitis are also exclusive on humans. So most of the epidemics are in isolated collectives, work camps, recruiting camps. So in Malaysia, the barracks, army barracks, and in the past also the national service camps will see minor epidemics occurrences of uh, meningococcal infections. So lethality is quite high if untreated, but if treated early, it is close to 1%. Meningitis grows also on blood agar, as opposed to Neisseria gonorrhea that only grows on chocolate agar and Martin agar. Okay, the Neisseria gonorrhea does not grow on blood agar. So capnate environment will also enhance growth, but it's not required for Neisseria meningitidis. Then to determine the serogrouping of the Neisseria meningitidis, latex agglutination is used. Under the family Neisseriaceae, so also short cocobacilli or coccoid bacteria, oxidase positive, that acts as an opportunistic pathogen. The type species is Kingella kingae. It's a normal oral flora, but can cause infections of bone, joints, and tendons. And now it is placed under also the HACEC group for infective endocarditis. Bordetella is under another family. It is often mistaken for Neisseria because of its shape and oxidase reaction. So it's good to know. They are parasites of the mucous membranes of humans and warm-blooded animals, and many are non-pathogenic. They are also isolated from eye infections and respiratory tract infections. So in the class beta-Proteobacteria, we have the order Burkholderia, family Burkholderiaceae, and also the genus Burkholderia. So the type species here is Burkholderia pseudomallei. Previously, it was classed under Pseudomonas. It's a gram-negative rod, oxidase positive, motile, non-spore forming, non-acid fast, with gram-negative bipolar staining. As you can observe here, the staining is stronger at the polar ends of the bacteria. So Burkholderia is an environmental bacteria found in the soil and water, and is endemic in Southeast Asia, Taiwan, and northern Australia. Infection is either through a break in skin or inhalation of aerosolized bacteria. So symptoms may include pain in chest, bones, joints, cough, skin infections, lung nodules, pneumonia, and mortality rate is very high even with treatment. Of course, there is a risk factor: diabetes, thalassemia, and kidney disease. Because Burkholderia is endemic in Southeast Asia, it is gaining importance, especially among the farmers and those working in the fields. Bacteria is grown on selective media, Ashdown's medium, and the detection is usually through complete screening. So the bacteria can be found in blood, sputum, urine, throat, and pus. So this is actually the characteristic of Burkholderia pseudomallei infection, where you can isolate the bacteria from all these samples because the infection is not localized. Okay, it is an accidental pathogen, but it is able to invade cells, polymerize actin, causing cell fusion. And it can spread easily from cell to cell. That is why it can it can be found in your urine, blood, sputum, pus, and throat. For Burkholderia malae, it is the causative agent for glandus, mostly affecting horse, although it can also invade humans through skin mucosa and form local ulcers. Under the order Burkholderiaceae, there is also family Alcaligenaceae, gram-negative, aerobic, encapsulated Coccobacillus. Here we are looking at the type species Bordetella pertusis, the causative agent for pertusis or whooping cough. So whooping cough is because when the patient breathes in, there's a whooping sound. It was first isolated in 1906 by Jules Bordet and Octave Gengot. So it is airborne with an incubation period of 7 to 10 days, where the humans are the only known reservoir. In the US, it used to kill 10,000 to 20,000 per year before the creation of the vaccine. But now, less than 100 patients die from whooping cough per year. Whereas in England, after vaccination, the infection rate has also dropped by 97%. So the vaccine available previously was whole cell vaccines. Now they are acellular vaccines from purified surface antigens. And it is part of the DTaP, diphtheria, tetanus, acellular pertusis vaccine, and is included in the immunization schedule in Malaysia. So if everyone is vaccinated, then it will not be a problem in the country. However, there are now sporadic cases among those that opt not to vaccinate their children, and this will cause infection clusters. At the immunization schedule, the vaccination is mainly to protect infants when they are most vulnerable. However, tweens between 11 to 18 years old, their immunity fades. So they also become vulnerable when someone who is not vaccinated is shows the disease. Okay, so this shows the importance of vaccination in order to provide herd immunity. Diagnosis is usually from nasopharyngeal swab on Bordetella agar, where the presumptive bacteria shows small circular pulvinate colonies. The bacteria is motile, oxidase positive, urease negative, citrate negative, and whooping cough can be treated with macrolides, for example erythromycin.